Good morning, friends. This is Radiation Oncology Stepwise Progress Part 2A is basically a conformal radiotherapy and a highly conformal image guided radiotherapy. We have divided this lengthy lecture in two parts. One is 2A and 2B since long lengthy lecture, so we had to do it. So traditionally radiotherapy basically used to have anatomical surface landmarks as well as radiological correlation with the help of X-ray imaging was basically a 2D planning. With the help of fluoroscopy, we used to correlate the bony landmarks and then we used to plan the tumor. Basically height and width is considered, depth is not considered here, so was basically a 2D planning. But in the modern era of radiotherapy planning, conformal radiotherapy has a very impactful role in radiotherapy planning, like image guided radiotherapy, and then its benefit is fully exploited when the full benefit exploited when the large organ motions are there and setup error is likely to occur. We begin from here. Like you see here in this image, we see the multi-leaf colligator irregular opening because tumor is not in a square shape, in a rectangular shape. So we have found out the solution to open the multi-leaf colligator. This blocks the radiation beam and opens only the irregular area. But was it sufficient? Certainly not, because the tumor is not only irregular. Tumor may be a concave, tumor may be of somewhere thick, somewhere thin. So the radiation dose to the thin area need to be controlled, and radiation dose in the thick area need to be accelerated and a dose to be little higher as per the plane of radiotherapy at an isocenter, so that the adequate coverage should be given and the organ behind the thin area should receive a less dose in order to protect the critical organs. So all the patients treated with a conformal radiotherapy should be theoretically get benefit of image guidance radiotherapy and a stereotactic body radiotherapy. But the clinical situation where low dose radiotherapy required to tumor control, or palliative radiotherapy, or a superficial tumor are likely to get least benefit by highly conformal image guidance radiotherapy. Here you see here the linear accelerator, the lady sitting as basically on the treatment planning system, and that's entirely two different image. One is a machine is installed, suppose, and then the sometimes the linear accelerator equipped with a high kV imaging system and EPID, so that information goes to the console, and from console DICOM server to the treatment planning system, where the repositioning, recorrection of image and the replanning is done to get a final say for contouring as well as treatment execution. So few of the important definition I would like to share with you guys, that what is orthogonal imaging. Orthogonal imaging is basically a projectional view, is by definition a radiograph obtained, one is anteriorly and one at the 90-degree to the original view, so that imaging is known as orthogonal imaging. You must have learned a lot about the orthogonal imaging in case of a CA cervix, where anterior AP view is taken and then a lateral view is taken, so that the posterior portion of that backside and a posterior portion of a tendon can be position can be assessed, as well as the if it is a CT compatible um, uh, applicators, so that you can go for a proper imaging, contouring, and execution of a radiotherapy. So orthogonal imaging is form the basic requirement of radiographic film, that is two orthogonal projection of a region of interest. So that you see the AP view, and then at a 90-degree the another view is taken, that is the lateral view, so that you can see here the applicators, and then AP view and a lateral view of a pelvic tumor like in CS cervix planning applicator. So is orthogonal film. So what is stereoscopic imaging? Stereoscopic imaging is basically what we see actually is not sufficient. We require a stereoscopic image. Means if I take a two different angle cameras, so that the accurate imaging can be a picture about the tumor, a picture about the object can be easily understand by your mind. Like by the definition, like stereoscopic imaging is a technique used for creating an enhancing image which have a depth showing two different by taking two different slightly offset images separately to each eye of the viewer. Both images are of a same object but taken from a slightly different angle, so it creates a different perspective. So here in the see the boy is taking a left camera and a right camera image of a same object, so have a two different perspective regarding the radiotherapy planning. So you have understand the tumor, better geometry of a tumor, and a posterior extent of the tumor and a depth. What is digital reconstructed image? Digitally reconstructed image are a simulation of radiographic images produced through the prospective projection. What happens here in that, like we start contouring after the CT simulation, all the slices having first taken at the central section of the slice where the tumor is the most bulky, and from there to upward slices those who are having a tumor, and a downward slices those who are having a tumor. So we contour all. After contouring, then we do a tumor plating. That was used to be done by us in our residency program, and the contour used to plot the tumor on the CT scan on the there is a CT scan the image. So after combining all the CT slices, those having a tumor, after contouring, we create basically a DRR image. So you see here in this diagram, and the diagram, yes, this is diagram that we have plotted all the tumors serially, not leaving any slice in between, then and also taking a margin, and then create a volume of data, and then DRR images created. And nowadays it is very simplified because of advanced treatment planning system we do have. So after that, the DRR images is, I told you how to create DRR images. And you see here in the head and neck cancer patients, you see when you contour the primary tumor and the organ at risk also, so that you can understand the dose deposition to that area, coverage of a dose to the critical organs should not be more than what is required. as per the tissue tolerance dose. And then we see definitely the tumor coverage area, and then we basically align the beams eye view after taking the DRR images. That's another term, that's a beams eye view, that if you put beams, it demonstrates the geometric coverage of a target volume by beam, and also along with the shielding and MLC are designed on the beams eye view, and this is very useful in identifying the best gantry angle, collimator angle, couch angle at the time of radiation. So a beam's eye view give a very good idea about the beams, this thing, angle of a beams and the width and depth of the beams. So you get, after DRR images on the 3D planning systems, the beam's eye view, and you put these blocks and the shields, and then you on the treatment planning system, and you can adjust the dose as well, and the margins, correction of margins. Though actually speaking, the imaging has a vital role in a play in concept of a modern radiotherapy planning. Imaging has two types, basically highly sophisticated imaging technique and in-room imaging methods. So image has a role. So the image has been divided into the highly sophisticated imaging and an in-room imaging methods in order to further enhance the radiotherapy accuracy as much as we go to the conformal radiotherapy in depth. So what are the sophisticated imaging techniques are CT scan, MRI, PET scan. They all obtain the 3D images of target volume as well as the biological information and the functional information of a target volume by the help of PET CT scan. Thus it's enabled the precise and accurate treatment. Also, we have gone up to the extent of the fusion technique like the CT scan and MRI fusion, CT scan and a PET fusion to accurately delineate the tumor. But have you heard about the CT PET imaging? You must have heard. CT MRI imaging fusion, you must have heard. But have you heard about the MRI PET fusion? Certainly not. Why? Because the CT is the baseline, because CT provides the electron density as the soft tissue density perfectly correlate, so the dose calculation is become very easy. So that's why the CT is the baseline for any form of radiotherapy planning till date. Planning with a beam shaping in an isocentric or a non-isocentric geometry to get a good target volume coverage because of these imaging system. You see a simulation, the planning first step is after that complete diagnosis and this thing, and then a staging workup. If you plan for a radiotherapy, then you go for a CT simulation. The CT scanner are used to localize the treatment volume as per the prescription. The machine are exactly the same CT as other CT, but this CT scan, CT simulation have a flat couch, and the diameter of the aperture is in the traditional CT scan, diagnostic CT scan is 70 centimeter approximately, but here you get a large diameter, almost 85 centimeter, is basically to accommodate suppose the patient is on the breastboard for the simulation CT or a head and neck rest, the complete orphic cast, you are getting a CT simulation, so that you required a bigger aperture. So a CT scan nowadays is fully built with the KV imaging system and even the mega voltage and a kilo voltage imaging system, as well as the electronic portal imaging devices, and then also respiratory sensor uh, uh, imaging system, and the real-time 3D methods. So these are the uh, allied portion of machine. They cover the help in the planning so that we can accurately delineate the tumor and the beam alignment is perfect, so that correction and recorrection on the treatment planning system after acquiring the imaging, we can go and then simultaneously or in between the treatment we can correct the image, or prior to the start of radiotherapy planning we can start correct this thing. So there are entity called image in room imaging technologies. This very technique helps in obtaining the target volume, position and its movement during the treatment and in between the treatment, that is intrafractional or interfractional. So in room imaging with a reference image and apply method in room imaging to correct the target volume and a patient setup error in order to get an optimized target localization. So the in room imaging in which the you take imaging during the radiotherapy, just before the start of a radiotherapy, or in between the two fraction of a radiotherapy, and usually linear accelerator are equipped with the KV imaging system, and sometimes in Bill cone beam CT is a most important requirement for delivering the SBRT. This is also helps to provide the feedback that may help to adopt the subsequent treatment fractionation according to tumor response. That is called adaptive radiotherapy. Suppose within the 20 fraction the tumor is shrinked almost half of its volume, then we have to adjust the replan the patients. That can only be done if daily online imaging you are doing, so that you see the tumor status, response status, as well as you can escalate the dose or replan the readjust the boundaries of a tumor, geometric boundaries of a tumor, as per the objective response, and basically it is called adaptive radiotherapy. So in room imaging application, image guidance radiotherapy is a modern external beam radiotherapy technique such as intensity modulated radiotherapy or a volumetric modulated arc therapy, stereotactic radio surgery or stereotactic radiotherapy have helped to reduce the normal tissue radiation dose without compromising the radiation delivery of tumoricidal dose to the target volume. However, there's a great deal of uncertainty in defining the position of target during the radiotherapy as well as in between the two fractions of a radiotherapy. Reason is that target may move during the treatment due to respiratory breathing, peristaltic movement for a GI tumors, and a bowel movements and cardiac pulsations, for mediastinal structures, urinary bladder and rectal filling may lead to the movement of a prostatic tumor. Hence, we need to develop the strategy to measure and monitor the correct these uncertainties. So this leads to evolution of various in-room imaging technologies which enables to correct the setup errors, anatomical changes related to weight loss or movement of internal organ. Also, we go for a CT-based brachytherapy in CS cervix. Here, the CT compatible applicators are used, and then we take the volumetric imaging with the help of CT and MRI, and then we contour this thing and then can deliver the radiotherapy. For applicator identification and its reconstruction to plan optimized 3D planning, isodose distribution is reviewed, optimized on the visualization of a dose distribution to tumor as well as cuticle structures. So the basic concept of image guidance radiotherapy planning, the traditional radiotherapy carries a disadvantage of making a significant number of assumptions in its technique. That is, we cannot assume the things like a tumor movement is fixed. Every individual, the tumor movement, extent of tumor movement is different. And also the 3D data set which we acquired during the simulation is basically a single snapshot on that particular day and that particular time. But on the day of delivery of a radiotherapy, this single snapshot is not going to help. Sometimes the movement is there of a tumor movement, so that online daily imaging is very much required for the image guided radiotherapy. Including a lot of assumption based on the prior experience and a literature to finalize the CTV earlier. What we used to assume the expected range of tumor and expected microscopic range of a tumor. The expected range of a movement of a tumor is still can be controlled, but the microscopic range of the tumor to define the CTV still is a problem. So assumption about the expected range of organ motion lead to the tumor motion with the belief that assumption hold true for all patients during the daily treatment fractions of radiotherapy. So although no, the individual we have a movement of a tumor like in a prostate tumor after blood and rectal refilling, a movement may be different for a different individual. So we cannot expect or we can predetermine values data we should incorporate here. We are not sure about the extent of a movement, so that we are not sure about the extent of a margin to be taken. So however, I have given assumption of a dose calculation. If on as a assumption, dose calculation is done on the CT image data set on the treatment planning system, and dose delivered throughout the entire course of radiotherapy is basically a gross error, because internal organ motion like target volume with respiration, peristaltic movement, and a cardiac pulsation, patient weight loss during the radiotherapy, the change in the treatment volume, blood and rectal filling lead to the movement prostate tumor. So these changes in the target volume, deletion, and as well as the large volume of a normal tissue can be incorporated in the radiotherapy, which we don't want. So IGRT give a method to capture this information on the regular during the treatment course in form of serial snapshots of a CT images in a means of verifying accurate, precise radiotherapy delivery in terms of image guidance. This ensures the delivery treatment matches the intended, accurately targeting the tumor while minimizing the collateral damage. You see here in the picture D, the linear accelerator head is giving the treatment beam. So the same beam is being utilized for the for EPID, electronic portal imaging devices, so that we can also know the treatment accuracy and then image guidance with the help of electronic portal imaging devices, so that we can see if there is a gross error, that we can repositioning of a beam alignment or width or things can be changed according to the most appropriately required tumor volume. So dose delivery may be minimized by use of appropriate localization devices, and the PTV margin occasionally replanning may require if a gross deviation is formed, and a counter check of imaging beyond the predetermined target volume of a margin is being done. IGR2 also allows the assessment of geometric accuracy of the patient model during the treatment delivery. It provides the method where the deviation of anatomy from initial plan are determined and these informations are used to update the assumptions. The correction strategies may include daily positioning to register patient position in accordance to the base plan or a recalculation of treatment delivery in real time in order to reflect the patient presentation during a given fractionation. So, this is very important that if we follow, though it's very difficult, but follow the correct strategy includes daily repositioning to register the patient position in according to the base plan, so that if recalculation of a treatment delivery in real time is done, that is most ideal, and to reflect the patient presentation during the given fractionation, and then so you have a more accurate planning by doing this method. The philosophy of writing the treatment planning according to difference between the actual patient anatomy on that given day and then the snapshot of a planned treatment or as present is basically adoptive radiotherapy. The final objective is to re-evaluate the certain situation, redefine daily positioning for radiotherapy treatment to keep on the same track as predefined and intended treatment plan for radiotherapy. There are technologies and solutions for all a collection of margins and errors. So what are the margins and errors? The error in radiotherapy delivery is defined any deviation from intended planned treatment planning. A great degree of uncertainty is related to radiotherapy practice may be in form of three type of uncertainties. One is mechanical uncertainties. Mechanical uncertainties is taken care by the radiation physicist, like treatment unit, gantry angle, couch angle, collimator angle. The brakes are effectively applied, and then their moments are effective and accurate. The second uncertainty is patient uncertainty. Uncertainty is not a very big problem. Is basically related to ability to lie comfortably in the certain anatomical position, and then the same position where the CT simulation is being done and cooperate during the treatment planning. So it's a duty of radiation therapist technologist to take care of these things, and also furthermore it is a duty of a radiation safety officer to educate and skill their boys or girls of a radiotherapy technologists to how to handle this kind of situation. But there is a very different things, uncertainties, that is geometric uncertainties. Geometric uncertainties are pertaining to the position and motion of a target volume which may occur during the radiotherapy or in between the two fractions of a radiotherapy. The uncertainty may be result of a combination of systemic error and a radiation error. So what is systemic error and random error? So systemic error is basically a treatment planning error and introduced into the chain during the process of simulation, patient positioning, and target delineation. These errors, if not corrected, this is very serious issue. If it is not being corrected, would affect all the treatment fractionation uniformly. Thus, it is very important to correct the systemic error from very beginning of the treatment planning. And then that's the second is a random error. Other hand is basically a treatment execution error which unpredictable and varies with each fraction, is basically lie on the hand of a domain which basically tackled by the radiotherapy technologists. A good radiotherapy technologist can eliminate the random error by using his or her skill. The systemic error shift the entire dose distribution away from CTV, that is most dangerous, and then systemic error is more dangerous because it will affect more a much larger impact on the treatment accuracy. Henceforth, therapeutic ratio is also affected, so that it need to be addressed very seriously. The margins are added to the CTV to take up these errors into the account. These margins are the geometric expansion around the CTV and may be, sometimes uniform, sometimes maybe non-uniform margins depending on the expected errors. These margins ensure that the target volume and planning goals are met despite the variation during the radiotherapy or in between the two fractions of radiotherapy. ICU 62 reports, which is launched in 1999, define the PTV, CTV, and GTV along with the internal margin and setup errors margins day-to-day practice to get a planning treatment volume. The depending on the observed systemic and random errors in a given setup for particular treatment site, varieties of advice is given in the literature to correct these PTV margins. So in these pictures, you see here you can interpret primary tumor as well as organ risk. So during the rechecking on the treatment planning system, you can understand the how much dose is going to the GTV, how much CTV, and then more focused and what is the PTV coverage area. To enhance the therapeutic ratio, a host of a correction strategy may be applied to reduce the margin. Errors include online correction or offline correction. Online correction means that just before the radiation, we do the online correction, and offline correction means between the two fraction of a radiotherapy if we correction made. Tracking and correcting the organ motion to help to reduce the internal margin while improving the treatment accuracy, and positioning directly with the help to reduce the setup margins, henceforth reducing the unrequired PTV margin. You see here in the typical linear accelerator, modern linear accelerator, EPID is inbuilt APID is there, so that you deliver the radiation and then you get an APID image. You can see on the from the console to the take it to the treatment planning room, so that you can see the plan is in your plan is whatever the plan of a radiotherapy is there can be counter checked by the electronic portal imaging device. Sometimes the dose scale deposition also there, so that you can see the dose received by the particular area. Sites where the large daily shifts are anticipated, for example, the thorax tumor, abdominal tumor, and a pelvic tumor in the mentioned sites, even a small shift in these areas will lead to the alter the dose distribution with the adjacent critical structures. For example, paraspinal tumors, intracranial tumors, close proximity to optic chiasma, best managed with daily imaging because you don't rely that one single snapshot of a CT scan is sufficient for the accuracy of the treatment. So data of online correction shows that maximum errors occurs in the thorax and then followed with abdominal error and pelvic tumors. And but natural, the thorax error is why it is because of the lung respiratory movement. So minimum error were observed in head and neck cancer. So this ends the conformal radiotherapy basics of part 2A. But what about the part 2B of radiotherapy stepwise progress? We'll be exploring their various imaging modalities used in the image guidance, as well as the what are the most advanced treatment planning, the saber knife, and what is the real-time tumor tracking devices and how we do it. Thank you very much for your kind attention.